Hi, I'm Jane Myles, and today I'm pleased and excited to say hello and welcome everyone to TMA's Ask the Expert Dermatomyositis edition. Really excited that you're with us today, wherever you're joining from. As I said, my name is Jane Myles, and I'm living with dermatomyositis here in California and really excited to be part of this event. I really want to call out and thank Pfizer for supporting the dermatomyositis programming during Myositis Awareness Month. So we want to know where you're from. Please just drop that into the chat for us so we know who you are, where you are, and kind of get a sense of the community who's showing up with us today. Just make sure that your message is sent to everyone by using your drop-down box at the bottom of the chat. And I want to give a call out and a thank you to TMA because since 1993, the Myositis Association has been working to improve the lives of those affected by myositis through research, advocacy, education, and support. Our dream is for a world without myositis, and every day we work toward that vision together with you and hopefully for you. And now I'll hand it over to Rachel to take care of some housekeeping.
Yes, thank you so much, Jane, for hosting, and thank you, Dr. Ascherman, for being here today. I wanted to let the audience know that everything you could possibly want to know or learn about myositis, you can find at myositis.org. We have that here, and we'll also put it in the chat in a little bit for you. Before we get started, disclaimer, TMA does not give medical advice, and we ask every speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel. Please put any questions you have in the Q&A box. Any questions put in the chat box may be missed. Applicable questions submitted when you registered are being entered into the Q&A by TMA staff, so no need to submit again. Questions that do not pertain specifically to this webinar may be answered in future programming. And again, please let us know in the chat where you're joining us from and go ahead and interact with each other. Now I'm going to launch a poll. One moment. And launch. You should see it on your screen. What have you done or are you planning to do to raise myositis awareness? You may decide to share your story or myositis fact on social media. You might find somebody who doesn't know anything about myositis and tell them everything you know. Maybe you organized a first pitch or submitted a proclamation request or did some other similar myositis awareness raising. Perhaps you donated to TMA. If so, thank you so much. Wore awareness gear, asked your rep to sponsor House Resolution 277 and other. Please share in the chat. We have about half of the people in the audience has participated. Okay, I'm going to end the poll and share the results. All right. So you guys, 81% of you have had a conversation about myositis with a friend, coworker, or family member who didn't know. And let me tell you, it's a very simple way to spread awareness and it's very easy to do. So congratulations on keeping it simple. And then second place, sharing your story, which is so powerful. And we will put a submission link that you can share your story in the chat. And also we will be sharing stories afterwards with at the social hour. So we have 36 active regional support groups and 9 affinity groups. You can find them at these links. We invite you to attend. We also wanted to highlight House Resolution 277. We'll put a link in the chat that you can ask your representative to co-sponsor. So thank you for that. And then, of course, we can't do it without your donations, and we appreciate each of you who have supported us. So thank you. Back to you, Jane.
Great. Well, thank you so much, Rachel. Thanks for all the organization that you do to keep the ship running. And now I'm really thrilled to introduce our expert for this particular session, Dr. Dana Ascherman. Dr. Ascherman is the Margaret Jane Miller Endowed Professor of Arthritis Research and the Chief of the Division of Rheumatology at the University of Pittsburgh School of Medicine. His research has investigated the role of cell-mediated immunity in the pathogenesis of idiopathic inflammatory myopathy, as well as myositis interstitial lung disease. Wow, that's a mouthful. So, fortunately, those are not new words for me. Dr. Ascherman, welcome. And now we're going to move into the Q&A portion of the program. Lots of you have submitted questions already, and please keep adding questions to the list. We'll do as much as we can to cover your questions. And Dr. Ashman and I are going to try to use a little framework like let's start with diagnosis, then we'll talk about initial treatment plans and modalities. What do you do in the maintenance phase? And if we have time, we'll move on to like what might come next. So, with that in mind, I'll just share a tidbit. And um, I was diagnosed in 1997. And I was really fortunate because I happened to see a dermatologist and I went with a completely different idea in my mind. And very quickly, I realized there was something happening here that was not at all what I had imagined. But I feel very lucky that I had a derm who recognized Gottrin's papules and immediately said, I need you to let my residents see you if you don't mind. And of course, I was happy to, but going through that whole mental process of what are those? So, Dr. Asherman, is that something that you see in the patients that you're diagnosing, or is my situation a little bit different? Or how would you describe the diagnostic process?
So first of all, thank you for having me today. I'm very happy to do this. Um, I have a lot of sort of fun connections with TMA, and so again, it's a pleasure to be able to interact with all of you and try and answer some of your questions. And as I told you before, Jane, my disclaimer is I'm not a dermatologist. Um, but I think the key point that you've raised here is that, there are a number of different types of physicians really who contribute to the care of people with dermatomyositis, be it, the dermatologist, the rheumatologist, pulmonologist, if there are other organs besides the skin and the lung I'm sorry, the skin and the muscle that are involved. And, unfortunately, there's a little bit of variability depending upon where you live. There may be, expertise in dermatology in one area, whereas it's more in rheumatology in another area. But, I think the key thing is that, from a physician perspective, is that we have to keep our respective communities educated so that, stories like yours, um, you know, are the norm in the sense that, we can have an astute physician, a dermatologist or another subspecialist who is able to recognize the problem in time to do something about it.
Well, that actually cues up one of the first questions here. Do you think it's helpful to have an immunologist as part of the patient's care team?
Um, it certainly doesn't hurt. I mean, I think that one of the things that we have seen um, is that, and this is a good thing, but there are a dizzying array of new treatment modalities that are becoming available, are available or becoming available. And a lot of these drugs, the discovery phase has been driven by immunologists who understand the sort of the pathophysiology of the disease. I mean, our holy grail in general in treating these and other rare diseases is that we have to better understand them at the level, sort of immunological, the immunological basis for these conditions in order to develop more targeted treatments. Um, but I think what you're asking is, a clinical immunologist, not just someone working at a lab bench. And I think that the reality is, the way that medicine is sort of structured now, um, clinical immunologists are often allergists. I mean,
Ah,
they're more focused on allergy or maybe immunodeficiency as
right.
opposed to autoimmunity. But again, I think that somebody who is well trained in that arena can certainly make a valuable contribution. Um, but the hope is that the rheumatologists and the dermatologists who are treating also have a background in immunology so that we, you know, presumably understand the disease at that level.
Well, there are a lot of different presentations of DM. There's even a typical DM, I think. So, as a clinician, what are the markers and signals that really point you towards the DM diagnosis first?
So, I, I mean, this completely depends on um, how the problems manifest or develop. So some patients with dermatomyositis will present with both muscle weakness and a skin rash at the same time, but that's not always the case. And so maybe your example is the best, or the most, illustrative in that it's not so hard to make a diagnosis when somebody has sort of full Monty, all the myositis and the dermatomyositis and the skin manifestations. But when it's more subtle, um, like as in your case, and I'm sure for many of the people that are on the line here, um, it then the difficulty is what else could this be confused with? And so one of the first things that comes to mind in the realm of autoimmune disease is lupus. So there are, you know, variants of lupus which are predominantly skin, and a lot of the rashes, and many of you, I suspect, on the line know this already, but it can look very similar. So, and it's more subtle things like the Gottron's papules or some of these things that are maybe we only see in dermatomyositis, but not in cutaneous lupus. But that takes recognition. Somebody has to have an index of suspicion to be able to do that. I mean, there are other sort of clinical clues, um, but and not everything that looks like dermatomyositis is even an autoimmune disease. I mean, there could be some drug eruptions or reactions, other things that look like this, but um, at the end of the day, though, there are a few what we call pathognomonic findings of dermatomyositis that would separate these out. So one of them is Gottron's papules. The other one um, is, the rash around the eye, which we call the heliotrope rash, which itself can look very different in different people. It's not always like the textbooks make it look. But those are the things that we use clinically apart from all the testing to start making these distinctions and arriving at the correct diagnosis.
So, let's assume that you were lucky and you got a diagnosis in less than 3 years, which is not the case for everyone. A lot of people get started on a course of therapy, and that course of therapy seems to be very individualized. Like you're saying, it depends on what you present with. It depends a lot on the most important symptoms to deal with immediately. So we've had a lot of questions about that, like how might one deal with something like dysphagia, or maybe at presentation, the worst thing for you is the dealing with itchy skin, scalp, hair loss. So, talk us through how you determine what's the right course of therapy for the individual. I'm not asking you to tell us any individual therapy, but how do you discern that?
Well, I mean, that is a big challenge, from I think the treating physician's perspective. But I guess basic sort of ideas are that, you know, and maybe this is a shortcoming in the way that, with our current knowledge that we approach conditions like dermatomyositis, but we are very much, treating based on what the particular organ manifestation is. So, we don't have, one size fits all treatment for dermatomyositis. It really does depend upon what are the tissues that are involved most prominently. And that, sometimes the treatments are the same for different organ manifestations, but sometimes they're very, let's say they're skin specific treatments that we might, if somebody doesn't have significant muscle weakness or extramuscular organ involvement, i.e. the lung or something like that. So, and then at that point, that's where we sort of, you know, kind of thinking about individual medications or combinations. And then this is true of all of medicine, but sort of trying to make a calculation almost of efficacy versus side effect. Um, and, that's very much a decision that we try and tailor to every individual. It's not, we can't come into it with a completely preconceived or sort of algorithmic approach.
Right.
I'm not sure that answers your question
Well,
exactly,
it
but
does. And so the short answer is it depends. But I don't mean to belittle that. I mean, I think that's the art and science of medicine, right? So you have a toolkit of different medications to use that then you apply to the individual patient setting and work with the patient to determine what's the best current approach. But I can remember those days really clearly, and of course 1997 we didn't have a lot of the stuff we have now. But um, my big goal at that front end of the disease process was first, let's get the symptoms under control, but then get me off this stuff as fast as possible. And we've had a lot of questions about tapering. So can you talk a little bit about tapering, especially steroids?
right.
And then how you move people into other treatment regimens, even in the early phases of their disease process.
So, there are exceptions, but in general, we often are using steroids first line. Um, but I think that we know enough about these conditions that really, in most cases, even from the outset, we should be starting people on steroid plus, meaning another immune modulating or immunosuppressive medication. And part of the reason it's twofold. One is to better control the disease as quickly as possible to limit damage, but the other is to get, a non-steroid medication on board so that we can taper the steroid more rapidly than if we were just treating with steroid. And that often I think presents sort of a almost an emotional challenge probably for you as the patient, because it seems that we're throwing all these toxic medications and at people, but the reality is that in the long run, many of these other immunosuppressive medications are safer than long-term steroids. So that is you know, a really a primary goal in almost every case is treat for as briefly as possible with steroid. But again, to accomplish that, there has to be something else in place that will act instead of the steroid as we taper the steroid down. Otherwise, things are just going to recur and flare up again.
So the treatment toolbox has changed a lot lately in a good way. Um, do you find that drugs like methotrexate and Plaquenil are still almost in that first horizon of treatments along with the prednisone, or are you seeing people move more to IVIG right up front, or even to rituximab?
So I think there are a lot of factors that go into that decision of what that other agent should be. Um, Again, I think it has to do with the range of um, disease manifestations or organ manifestations that. So, for just as an example, if someone had bad skin and muscle and lung, I would go to rituximab maybe before methotrexate as that other agent. But that's, and I think the other comment to make at this juncture is, and maybe this is a little bit controversial, but I think that most people in the field now don't see Plaquenil as a great medication, even for the skin disease, even though like in cutaneous lupus, it's first line for skin disease. Um, I'm not saying it doesn't work, but it doesn't work as much as we think it should. Um, so, so often I will think about, let's say, methotrexate as the next um, thing that I would try. Now IVIG is approved. It used to be that, we would have to run through a certain number of other medications and have them not work before we could get IVIG, because clearly IVIG works for both
Yeah.
skin and muscle many. So I think that our um, movement to IVIG is probably earlier now than it was 5, 10 years ago. Although having said that, in most of my patients, I might still try something like methotrexate before IVIG. I mean, there's several reasons for that, including, comparing oral medication versus an IV medication, and IVIG, although in many respects is safer than immune suppressing medications, there's no such thing as a completely risk-free medicine. So there are things that we have to look out for all of these medicines, and those are, again, the equation, the calculus is different for every individual depending upon what else is going on.
The art and science of medicine, right? So I remember at the front end, I heard this term taper, and I kept wondering, how long will that be? And it was a long, long time. So we have a question from a patient. What are the guidelines on taper, and how do you actually start to comprehend what the time frame might be?
So I think that in general, before we taper, we like to see some evidence of disease stability. So um, we kind of think of steroids as induction treatment to really get things under control as rapidly as possible. And then, as I said before, hopefully we start another medication in preparation for this tapering phase. But, you know, it may be that within, a month or two that we start to taper. But um, ideally, I would say that we would like to see the disease stable for, you know, uh, a couple of months before we do significant taper. We might start the taper earlier, especially if there's another medication on board. But um, I don't think that we can realistically think about getting people off, let's say, steroids until they've demonstrated that there's some, at least for a couple of months, that things are stable or under, you know, in
So
better
let's talk
situation.
about what stable means. Is that looking at, say, your CK levels? Is it evidence of rash? Is it your muscle strength? Is it all of those things?
Well, the short answer is it's all of those things, but I think to give that a little bit more granularity, I think that let's take the skin as an example. Um, Ideally, you'd want things to be in complete remission and things to be completely resolved with the steroid, but that's not always the case. Um, but at least I would say that getting things to a state where there's been definite improvement and that improvement has been maintained for a couple of months, even if it plateaus. So let's say 50%. I mean, that's not as good as 100%, but it's better than the start, right? And maybe there are other things over time that can be done to get that down to, 80% or 100% improvement. But at least to sort of direct the stage where we start tapering steroid, I would say that there has to be some clinically meaningful improvement and that's maintained for, a couple of months before we do serious tapering. I realize that that's still a bit vague, and I think um, that's going to be a little bit different for every individual depending upon, the severity at which they started, etc. But there's no question that we get to a point where we have to weigh um, kind of the um, negative aspects of persistent or smoldering disease versus the accrual of side effects from steroids. So, at some point we have to make a decision, yes, maybe this isn't back to a complete remission, but if we don't make any other changes, we're going to run into trouble from side effects from steroid. And that's a judgment call. Um, but there are some other indicators. I mean, certainly for muscle, we use muscle enzyme levels as a gauge of what's going on. Um, I think part of the problem is, although there's a lot of research in this area, we don't have a great simple clinical biomarker, let's say, to say how is the skin doing? How much of this is active skin disease versus, you know, I don't want to say permanent damage, but let's say damage. Um,
Right.
and we in some ways we have more tools for muscle than we do with skin, although we might repeat a skin biopsy actually to see what's going on, just to really be able to answer that question. So, in general, in this field, I mean, one of the things that we struggle with, frankly, is having great biomarkers of what is the activity, I mean, sort of real time of the disease, and can we tell that in an organ specific way, skin versus muscle versus lung? And, you know, and can we use that as a barometer to see how we're doing with our treatment in terms of efficacy?
So let's flip just a little bit and talk about symptom management and this itchy scalp, the um, gastroparesis, maybe dysphagia, maybe calcinosis. Oh, how would you recommend that people work with their care team to address those symptoms?
So I'll try and tackle those individually, those particular examples that you mentioned. But um, again, the pat answer is this involves coordinated care between different specialists. So, for um, itchy scalp and calcinosis, that's the dermatologist and the rheumatologist. Um, for dysphagia, let's say that might be the neurologist and the rheumatologist, and maybe even um, the um, you know ear, nose, and throat doctors, let's say. Um, but so there definitely has to be coordinated care. Um, I think that you know, just to take specific examples, for the itching, I'm trying. I'm not good at walking and chewing gum at the same time. I can see like all these messages floating by, or comments in the chat, and I see things about different shampoos and stuff like that. I think that there's value to, there are probably various shampoos, topical agents that can be helpful, antihistamines, for the itch. Now we're talking about, there's been a lot of research, and many of you are probably, familiar with Dr. Victoria Worth from the University of Pennsylvania, one of our champion dermatologists in the field. And she's done a lot of research, um, actually with the cannabinoids, and showing how, they interact with the immune system. And there's a particular inflammatory, well, itch mediator, interleukin 31, that they've been looking at for a while, and maybe as a mechanism of how CBD preparations work. So some of that isn't ready exactly for prime time yet, but there's a lot of work um, going, and that's a case where we're not just treating a symptom, we're trying to get the root cause, no pun intended, um, for things like scalp itch. Um, so that's the example for itch. Now, calcinosis, um, very, very difficult, unfortunately, problem to treat, both in the context of dermatomyositis and other conditions like scleroderma where that can occur. Um, they're actually, even here at University of Pittsburgh, not for dermatomyositis specifically, but there's some small investigator-initiated clinical trials looking for things to help treat that particular problem. I'm going to I'm going to stop there because unfortunately we are lagging in that area. And then just to use dysphagia, go back to that one. I mean, that is a case where um, I think IVIG can be particularly effective, and we've known this for a number of years, long before IVIG was, FDA approved for dermatomyositis. Um, that's a particular treatment that is effective for that complication.
Yeah, we're so lucky now that we have these medications. And we'll eventually get to talking about what's coming next. But let's imagine now that you have a patient who's fairly newly diagnosed and they're, quote, a simple DM patient, so they're not dealing with another disease entity like rheumatoid arthritis. What's your thinking about exercise, especially in the early phase of disease, and how do you coach people on that, recognizing it'll be individualized? Because I was certainly told, yeah, that's to be avoided, and then we changed. I was working with someone who changed her mind on that. And then
Well,
what about supplements like protein drinks and things to manage muscle loss and wasting?
so um, one of the things that we have straightened around is this misconception that exercise is bad in the setting, even acute myositis. Now, it does have to be tailored to the severity and the activity that, if somebody with new diagnosis and active muscle disease, we're not saying to go out and go to the gym for an hour a day, but, it requires guidance and supervision from a trained physical therapist. But we talk about physical, graded muscle strengthening. So even early on, we want to institute some kind of structured exercise to try and really prevent excess muscle loss, muscle atrophy. I mean, and our understanding of what exercise does, even immunologically, has improved over the last 30 years. I mean, thanks in part to um, a lot of work that's been done initially by Helene Anderson and Ingrid Lundberg at Karolinska. I mean, they were, I'm not saying the only ones, but among the first to really look at the physiology of exercise as it pertains to myositis, and to try and sort of break down that myth that exercise is bad. Um, so I think we've moved past that now. Um, the supplement question, I'm just going to be honest. I don't know the answer to that. I'm not a huge proponent of supplements. I mean, I'm not anti-supplement either, but I just don't know at this point, is there benefit to creatine supplementation, for example, something like that. And you know, I I mean, I think people are looking at that, but I don't think that that is a sort of standard recommendation that we're making to people. At least I'm not. I mean, you know, I'm curious in some ways, particularly with people in the audience today, whether that's something they're being actively advised to do by someone from their treatment, um, teams. But at least, what we do here, and I don't want to speak for all of my colleagues at University of Pittsburgh, but Chet Otis and Rohit Agarwal obviously are here, and they are, expert clinicians as well in this arena. And we talk all the time about different approaches, and um, that's one of the nice things about being together in a group, is being able to collaborate that way. But I'm not aware that they are routinely advocating that either. But I freely admit that um, there may be others who have more um, expertise or definitive recommendations.
Well, as somebody who's worked in clinical research my whole life, I would say dietary recommendations in any disease state just seem hard to prove, generally.
Well, I think it's, there's no question in my mind that things like diet can impact this and other diseases. And again, I'm just going to say very openly that, um, I think both I as an individual, but even we as a field are a little bit behind understanding the science of diet. I think, and that's part of the problem is that, have we done controlled studies to really look at this in a rigorous way, the way that we would to approve a new drug, right? But that's almost what needs to happen to really, um, put some credible science behind this. And that would actually make it easier for everybody, even for us as physicians, to know, is there a rationale behind prescribing a certain diet, anti-inflammatory diet, Mediterranean diet? I mean, my gut feeling is that, there's value in these diets, but I don't know exactly how.
It's hard to weigh the evidence. I'll say it that way. Like, and I won't press you on that, but we have a great question here. Like, when should you involve a neurologist in your care team, especially after an initial diagnosis?
Well, I would say that certainly the neurologists are going to have the most direct input with respect to the neuromuscular manifestations, i.e. myositis. Whereas I'm not saying that neurologists can't deal with skin or lung or other organs, but that's not necessarily their wheelhouse. Um, and it just depends where you are. I mean, I'm not in any way trying to denigrate neurologists. Some of you, if you've ever heard Dr. Christopher Stein speak, she always refers back to this editorial that she wrote a number of years ago about sort of likening the difference between neurologists and rheumatologists to Venus and Mars. You know, uh, I actually think we're a little closer aligned, maybe, as specialties than maybe we once were. But the answer to the question is really where you are. So there are certain places where the neurologists really, that's where the myositis experts reside. It's not always rheumatology. It just, we're lucky here at the University of Pittsburgh because we have a great relationship with an experienced neuromuscular a neurologist. And I think, again, it's a common theme here, but partnership is key. Um, but
So maybe, I mean, not to put words in your mouth, but when you get diagnosed with a rare disease, you're going to take on some sleuthing activities, right? As a patient or as the caregiver to the patient. And maybe some of this is sleuthing out what's the expertise and discipline within the team where you are seeking care. And then if you think there's something else you want, you might want to explore if there's someplace else to go for a consult.
and I think that's exactly where an organization like TMA can be so important. I mean, for making that kind of information available to patients. I promise I didn't get paid by TMA to say that, by the way.
Well, we both love the organization for many, many reasons. Um,
But it's definitely regional. I mean, and that just reflects the fact that there aren't enough neurologists and rheumatologists to go around for this condition.
well, I mean, I grew up in rural Canada. The likelihood of anyone knowing what this was, if I had presented earlier in my lifetime, was nil. Maybe we'll change that over time. What do you think about stress and how that's involved in both the initial presentation of disease and then the ongoing manifestation of disease?
Stress is bad. That's my
Stress is bad.
um, no, there's no question that there's a direct interaction between stress and the immune system. You know, so does stress by itself cause these diseases? Of course not. But can it, be one of the triggers, lower the threshold for disease development? Yes. Can it, um, interfere with um, response to therapy, or can it impact the disease course? Yes. I mean, sometimes that's hard to quantify or show in a tangible way, looking at this cytokine, that cytokine in the blood work or whatever. But I was being intentionally flip because there's no question though that stress um, is really not helpful for this. But it's not just, stress is bad, but it really does impact the immune system and the health of the immune system.
So I'll just call out TMA because there are a lot of support groups here that help with the mental health aspects of rare disease management too. Um, this is an interesting question. What about a case when you might have high antibodies, but not a lot of physical manifestations of myositis? Is that normal? Does that happen?
It does happen. You know, and it's rare that we know before a disease starts that someone has high antibodies because if there's no clinical indication for doing that kind of testing. But I think the question comes up, how do we use things like antibody levels to track disease and what's happening? Um, and although it would seem intuitive that, if your antibody levels are climbing, that something is going awry, that that isn't universally true. I mean, we here and others have done research, for example, showing a relationship between the level of Jo-1 and those who have Jo-1 antibody, you know, and that there is a correlation between level of antibody and um, disease activity. Maybe it's even organ specific. But and this is a general tenet of, I think, of rheumatology and medicine, we are not going to treat just a lab test alone. I mean, that would certainly put us on high alert if we happen to be tracking those levels. And I'm not necessarily advocating for or against repeating the levels because I think that the way that these are tested in the lab, it's not quantitative anyway. But to answer your question is that it is possible to have a state where there's high antibody levels and maybe not super high disease activity, but certainly, you know, I would hedge my bets and say, I'm going to watch this person much more closely for a disease flare than,
What about the opposite? What if you're seronegative, but you're having a lot of symptoms?
well, that's just our problem with detection. In other words, Um, we know that there's a subset of patients who don't have these antibody markers, but they clearly have the disease, whether it's been proven by biopsy, muscle enzyme levels, appearance of the rash, and biopsy the skin. So um, I think both of those examples really emphasize that at the end of the day, it's we can be guided by these labs, but we are driven by the clinical picture, what's going on clinically with the person who's in front of us. Now we don't have x-ray vision, we can't always obviously see inside, and that's why we try and use tools like this. And it goes back to the comment I made about needing better biomarkers so that we can gauge disease activity. But I think here, ultimately the decision to treat or not treat is not going to be made on the basis of an antibody level alone. It has to match what's going on clinically with somebody. And we don't have enough evidence to say, well, you know, if we see rising antibody levels, even if someone doesn't have disease activity, why don't we put them on more medicine or different medicine sort of preventatively? And I just, because um, we don't necessarily have the data to say that that's an effective strategy. And we're talking about treatments that have their own side effects, morbidity. If we had, risk-free medications, well, then it would sort of be a no-brainer. We would, I shouldn't say a no-brainer, but we'd be much more likely
Makes
to hedge
sense.
our bets
Yeah.
and make a change.
What about biopsy? So I remember having a muscle biopsy, and I'm interested to hear, is there a blood-borne assay now that can replace that? I also had EMG, didn't love it. Um, so there's the initial process, but then how do you determine and decide whether or not somebody needs a rebiopsy?
Great question, and I can answer sort of both aspects. Well, different aspects of that question. I mean, there is no surrogate for a biopsy if you really want to know what's going on in the tissue. Fortunately, we don't have to subject everybody to EMGs these days. That MRI has, I don't want to say has supplanted EMG, but it's another way of non-invasively or more painlessly looking at muscle. But remembering that what we're looking for at MRI, we're not seeing inflammation, we're seeing fluid edema in the tissue, but we use that as a surrogate of inflammation. Um, but so part of it's, you know, we can get initially an MRI to sort of say, is there likely evidence of muscle inflammation, but still would need a biopsy ultimately to prove that it's myositis. But where the MRI can be particularly helpful is in the middle of, if somebody has established disease, but all of a sudden, they're getting weaker and it may not be heralded by muscle elevation of muscle enzyme. We often face the question, is this just a result of damage or is this because the disease is still active? And that's where MRI can be particularly helpful because damage, we see muscle atrophy, we see replacement of muscle by fat, whereas disease activity, we would see more of this edema or fluid in the muscle that would light up. So that's a strategy that many of us will take to sort of assess disease activity. I think that in the future there may be other modalities, like PET CT scan, for example, because that's the marker, the tracer that's used in PET CT is taken up by metabolically active um, cells. What does that mean? If there's active inflammation, those inflammatory cells are metabolically active, and they would, in theory, take up more of um, this marker. But we don't routinely recommend that. But that, uh, again, is another, at least conceptually, an approach to try and distinguish between damage and ongoing activity.
All of this filters through my little pea brain of like, yeah, we didn't have an MRI where I was getting treated. So all of this evolves with technology. So your toolkit evolves both with the treatments and with the diagnostic testing over time.
We definitely um, we certainly have more tools at our disposal than we did 10, 20, 25 years ago. um, and I think hopefully that trend continues. um, there are many of us in the field who are working on these biomarkers, you know doing a blood test to actually see if we can find something that at least parallels what's going on in the tissue in terms of inflammation. So your question is a good one. I mean, we don't have a replacement for biopsy yet, but I do think that there will be a point in the not too distant future where we have less invasive markers, at least so that repeat biopsies don't have to be done. I mean, that's, I'm sure, not fun.
Ah, it sometimes is necessary. But let's flip the page a little bit. And I recognize we have not covered every single question here by any means. What do you think is coming next in the treatment toolbox? Like what gets you excited and what are you curious about but not yet sure will work?
So there are a lot of new medications that are actually already in um, clinical trials, being evaluated, um, and in particular for dermatomyositis. I mean, these drugs still exist, but they've been looked at in other conditions. But we are, looking at targeting inflammatory mediators called interferons. Um, we are looking at medications like in the family of Xeljanz, which is, used for rheumatoid arthritis, but um, it basically inhibits some signaling molecules called um, JAK kinases, and um, there are, there's some very exciting data, not only in skin, but maybe even, or accumulating data that maybe that some of these things will be helpful for lung. Not that we don't have some other things, but I think so. The this part of the answer is that there are already things in the pipeline um, that we should have results in the next year or two from some of these trials, and we'll obviously have to see what that shows, but it's a very active area, and I think the positive message, or the hope here is that um, as we, there's just, I'll also say that in general, there's a lot more focus on clinical trials in dermatomyositis and myositis now than there was 10 years ago. So that in itself is um, really a positive advancement. I mean, half the battle is getting people to pay attention, enough people to pay attention that, they see the value in doing trials in rare diseases or rarer diseases. That wasn't always the case, and it's still going to be a barrier, but at least, you know, it's not as much of a barrier as it was. Now, are there particular strategies, that aren't in trial, but that I can sort of think of that might be, um, coming down the pike? I I would say this. I can't give a specific example, but um, with the advent of a lot of this new technology where we're looking at these diseases at the tissue level and at the level of gene expression, we're really understanding in much greater detail the actual pathways that are disrupted in these diseases. And as we build those, and by pathways, I mean different proteins that are conspiring or working together that drive inflammation. So we're 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 going to have an increasing array of potential things that we can target with medications. And the idea, the goal is to find pathways which are more uniquely expressed in dermatomyositis as opposed to somebody who doesn't have it, so that we can selectively target without having all the side effects that we see with a lot of the medicines that we currently have. So can we treat the bad actors and leave the important cells, the good ones, alone? I mean, that's simplifying a lot, but I think that that's becoming more of a reality as we can use what we're learning at the research bench to put together these pathways. And I think that even what we're seeing now, again, with the interferon targeted drugs, these JAK inhibitors, that all started because of people doing these kinds of studies and understanding what's happening at the tissue level, gene expression, and um, even in dermatomyositis, this whole interferon story started 20 years ago. Steve Greenberg, who's a neurologist, by the way, um, did some really elegant studies looking at skin and blood and looking at gene expression profiles, and really showed very conclusively that the interferons were playing a very important role in this, you know, at least the skin manifestations, if not the muscle and dermatomyositis. And so here we are. Hopefully, it doesn't take 20 years to get from discovery to treatment, but that just shows sort of the pathways that have opened up.
I do want to remind people, and Rachel just dropped it in the chat, that we have an informal, we'll call it conversational hour after this session that starts at the top of the hour. So there's a link here to join. I'm going to put you on the spot just for a sec, Dr. Ascherman, and no one I know who is interested in DM is not curious about CAR T. So I'm not asking you to predict how is this going to manifest in terms of availability, but how does that resonate on your interest level for treatments?
So I didn't mention cell-based therapies when you just asked what's coming down the pipe, but um, there are active clinical trials. We're involved. Many places are involved, and I actually think it's going to work. But I think the caveat here is that this is not a treatment for everybody. that it's really going to be, um, you know, on the spectrum of disease at the it's a treatment that would be most appropriate for people who um, are failing more conventional therapies and have, organ threatening um, disease manifestations that would justify the risks that are associated with CAR T cell therapy, which it's not, maybe as much as having a bone marrow or stem cell transplant, but the protocols as they exist now are not trivial. I mean, they involve conditioning the bone marrow sort of, and then, reprogramming cells from somebody and putting them back in. But there are derivatives of CAR T cell therapy that don't involve, um, pounding the bone marrow first, and but the same principle. And I think that is going to be. I'm very excited about that as well.
Me too.
So
Like
so so
super.
just to put it, I mean, this might not mean a lot to many people on the call, but there's something called bispecific T cell engagers, and it's more of it's a manufactured product, but it does in effect the same thing that cell-based therapies like CAR T would do. And that can be more of an off-the-shelf, I'm simplifying, but a little bit more of an off-the-shelf product, you know, not completely benign, but doesn't carry the same risk as CAR T. Um, and I think just from a practical standpoint, that is, as I said, a derivative therapy that might be more widely applicable to people with these and related autoimmune diseases.
Yeah, I'm super hopeful about it myself, and I hope I never need them myself too. But your statement about the shift in interest and the availability of new entities that are being tested is a profound change. And that is maybe the thing that gives me the most hope. So we are at time. I want to say thank you so much for your expertise and your patience. Apologies to our audience. I know we didn't get to every one of your questions, but now you know Dr. Ascherman and his team are great people to ask these questions to. And I hope that if you have the time, you can join us in the cafe chat. If you didn't register, there's a link in the chat box now, and hopefully we'll see you again in a few minutes. And Dr. Asherman, maybe I'll see you, well, first at the TMA annual meeting, but you never know. Maybe I'll get to Pittsburgh someday because I'd love to meet you and your care team.
All right, but hopefully not as a patient.
Well, thank you very, very much for your
Right.
time. And
As I
thank
said, it's
you
my pleasure.
for everything you do on behalf of patients.